working. What am I supposed to do with the Okay. Good morning, everyone. Am I audible? Yeah. So I want to thank Dr. Govil and Anant for having me here today. And it's nice to see some of my own students, couple of my own students here. And how many of you are here from Medanta itself? Okay, great. And from outside Delhi? Oh, where? NCR or Rajasthan? Oh, that's great. Okay. So I was asked to give a case-based presentation on a patient with cough, fever, breathlessness, and infiltrates on chest X-ray. So I'll start with the case history. So we have a 65-year-old female with a past medical history of hypertension, type 2 diabetes mellitus, hyperlipidemia, who presents to the emergency department with a 5-day history of fever and cough and shortness of breath for 2 days, which is significant, and a lot of fatigue. So when you hear this kind of history, you make a differential diagnosis in your mind, and the topmost diagnosis here would be community acquired pneumonia. So please make it interactive. You can also answer my questions when I ask you, okay? So the topmost diagnosis would be community acquired pneumonia, right? See, the other diagnosis which can present as community acquired pneumonia would be, especially in the setting of heart disease, would be heart failure, or exacerbation of an underlying COPD, acute bronchitis, influenza, URTI. Then the other less common situations would be pulmonary embolism, aspiration pneumonitis, and underlying interstitial lung disease and lung cancer. Okay, these are rare manifestations, but here, given the history, the most the diagnosis of choice would be community acquired pneumonia. Okay, so what are the points in history that you would like to elicit? For two reasons. One, to make a diagnosis, and second, to narrow down the microbiological diagnosis, and secondly, to target your therapy. So you need to ask for history of smoking, history of COPD, any chronic lung disease like COPD or interstitial lung disease, or any comorbidities like heart disease or heart failure, history of travel, right? Especially keeping in mind the COVID pandemic, history of travel to an area which has endemic diseases or currently going through a pandemic, especially of viral illnesses. Then exposure to contaminated water, animal, birds, because there are certain organisms which are transmitted through animal and birds and contaminated water and can present as pneumonia. Then any history of exposure to tuberculosis in the family or past history of tuberculosis, recent healthcare contact, very important. If the patient's had a recent admission in the last 90 days or has had history of taking IV antibiotics, any prior culture results if the patient has had any prior infection. And sometimes in elderly patients, these patients with community acquired pneumonia may present with non-pulmonary complaints. They'll generally be very lethargic, they have altered mental status, they may have sudden falls because of this. So you need to be very careful to reach a diagnosis. So on clinical assessment of this patient, you find that the patient is febrile, the temperature is 101.3 degree Fahrenheit, the blood pressure is around 90 by 60 millimeters of mercury with a heart rate of 124 per minute. Respiratory rate is about 30 to 32 per minute, and the saturation on room air is 90%. Right. So on examination of the respiratory system, you find that there are decreased breath sounds on the right lower part of the lung. It's dull to percussion, and there are occasional crackles as well. Rest of the systemic examination is normal. So as of now, what do you do when the patient is in the ED? So you do your ABCs, you take care of the air breathing circulation, you start an IV infusion, but be careful that you do not over transfuse, okay? Especially in the setting of a pneumonia, right? So what is after doing the ABCs, you send your lab investigations, the biochemical parameters, and the next thing that you do is for diagnosis of community acquired pneumonia is a chest X-ray, right? So a chest X-ray for this patient was done, and you can see you can see that there is an opacity, which is a well-defined opacity in the right lower zone. So the lab investigations come in and it shows a TLC of 18,000, thrombocytopenia of 80,000 per cubic millimeter, a blood urea of 80 and a creatinine of 1.8. And an ABG shows a slight acidosis, a pH of 7.30, PO2 of 54 millimeters of mercury and a PCO2 of 28 millimeters of mercury. So the patient is hypoxemic, is hyperventilating, and therefore the PCO2 is low. So, given this patient, the diagnosis is community acquired pneumonia because there is the clinical suspicion, clinical signs and symptoms which fit into community acquired pneumonia, and plus there is this X-ray which shows infiltrates. So, the diagnosis is community acquired pneumonia. And so, in the next 20 minutes or so, we'll talk about the different aspects of community acquired pneumonia, which is the definition, epidemiology, etiology, clinical features, investigations, diagnosis, the assessment of severity, treatment, complications. Okay, so what is community acquired pneumonia? How is it defined? It is an acute disease which involves the lung parenchyma, the infection of the lung parenchyma, and it is generally acquired outside of a hospital setting. So when it is acquired, the infection of the lung parenchyma is acquired outside of the hospital setting. It is called a community acquired pneumonia. Community acquired pneumonia is the most frequent cause of infection related death in the world. Okay, it is also the 8th leading cause of death worldwide other than the infection related. And it contributes to about 20 to 60% of hospital admissions, and out of these patients about 10 to 22% will need ICU admission, and out of these patients who need ICU admission, 44 to 83% will need some form of mechanical ventilation, 50% will have shock associated with their pneumonia, and the mortality rates vary from 11% to 56% depending on the geographical location of the ICU. So what are the common causative organisms which cause community acquired pneumonia? Okay, so you can broadly divide them into bacterial, viral and polymicrobial etiology. The bacteria can be further divided into 3 types: typical, atypical and PES pathogens. Okay, any idea what PES pathogens are? Okay, so typical bacteria, the most common bacteria which causes pneumonia is Streptococcus pneumoniae. Okay, and it accounts about 30% of community acquired pneumonia. The other bacteria, typical bacteria which cause CAP are Haemophilus, Staph aureus and Moraxella. Okay, so the atypical bacteria contribute about 22% of the incidence of CAP. And the 3 common atypical bacteria which cause CAP are Mycoplasma, Chlamydia and Legionella. So the PES pathogens are not a very common cause of pneumonia, community acquired pneumonia, but they are an emerging trend because of the increasing incidence of MDR pathogens. So PES stands for Pseudomonas aeruginosa, E is for ESBL producing Enterobacteriaceae, and S is for methicillin resistant Staph aureus. Okay, so these 3 pathogens which occur in individuals which have a certain risk factors which I will come to later. So the next common pathogen which is responsible for CAP is the respiratory viruses, of which influenza is the most common, and this accounts for about 10 to 30% of the total CAP patients. Then about 6 to 13% of CAP patients will have a polymicrobial etiology, and often this is influenza combined with a bacteria. So these were the Western literature. So what is the literature that we have from India? So we do not have very high quality evidence, but this is one study from the northern part of the country where they looked at a total of 225 patients over 2 years, and they found that the data was quite similar to the Western data, and they found that the commonest organism was Streptococcus pneumoniae, which is about 30%, followed by Legionella, which is the atypical bacteria, it's about 18%, influenza and 16%, Mycoplasma 7%, Chlamydia 5%, and so on and so forth. So the etiology of CAP in India is quite similar to the Western literature. So what is the pathogenesis of community acquired pneumonia? So the pathogen enters the lungs or the alveoli mainly through two routes, either through inhalation or through aspiration, right? So when it enters the alveolus, it multiplies rapidly. So once it multiplies, it leads to the activation of the alveolar macrophages, which releases cytokines. So on the release of cytokines, it leads to recruitment of the neutrophils into the alveolar space, and some of the cytokines also are released into the systemic circulation. This leads to generation of the alveolar exudate, which you can see on the X-ray. So those infiltrates are because of the alveolar exudate. So what are the risk factors for community acquired pneumonia? Any extremes of age, okay? Elderly and children are more prone to community acquired pneumonia. So in this presentation, we are going to concentrate only on community acquired pneumonia in immunocompetent adults, okay? We are not going to talk about children, and we are not going to talk about immunosuppressed adults, which have a different line of management altogether, okay? Then underlying chronic lung diseases, like I've already spoken about, patients who have, chronic and repeated aspirations, patients who have immunosuppressed state either because of medications or because of their disease itself. And one more important factor is patients who have lifestyle factors such as smoking, excuse me, alcoholism, and people who live in overcrowded living condition, which is very common in our country. So we talked about community acquired pneumonia, and then there's another entity called severe community acquired pneumonia. So what is the definition of severe community acquired pneumonia? So there is actually no concrete definition for this, but it is basically defined as a type of pneumonia which is severe in nature, which requires the patient to be admitted in the ICU, right? So then how do you determine that this patient has severe CAP? Is can be based on two scoring systems. The most commonly, and which the ATS and the IDSA recommend, is these criteria, which consists of two major criteria and about 9 minor criteria. So the two major criteria are the need for invasive mechanical ventilation and shock needing vasopressors. So if there is one major and 3 minor criteria, it predicts the need for ICU admission with the sensitivity of 84% and a specificity of 78%. If there is more than 3 minor criteria, the sensitivity decreases to 56% and specificity increases to 91%. So these criteria are one of the most used and most validated criteria for defining severe CAP, or the need for the patient to be taken care of or triaged into the ICU, right? So when the patient comes to the ED, if the patient has these criteria as satisfying the criteria for ICU admission, this should be based on the ATS IDSA criteria, which was initially introduced in 2007, and they were continued when the guidelines were updated in 2019, right? So this is what you use, and globally this is the system which has been used. The other scoring system is the SMART COP. Okay, so this again, low systolic BP. So about 5 of these are common. Both the criteria are common in both the scoring system. The only thing difference is the albumin level, the pH, and the and the PO2, right? So they talk about the PO2. So the presence of more than 3 points identified 92% of patients receiving IRBS. IRBS means intensive respiratory and ventilatory support. So if they on SMART COP classification or scoring system, if you have 3 or more criteria, the sensitivity is 79% and specificity is 64% in predicting ICU admission. The drawbacks of this system as compared to the ATS IDSA criteria is that it requires for the patient to have albumin levels, the PO2 levels and the pH, which may not be possible in all settings and might take time, which can delay the triaging of the patient and delay the initiation of the treatment. So that is why, for the ease of the availability of the criteria in the previous criteria, that is more widely used. So we talked about the risk factors in CAP. What about the risk factors in severe CAP? So the risk factors of severe CAP could be patient-related factors, age more than 65 years, presence of comorbid conditions. Like in our patient, the patient's age is 65 years. The patient has underlying comorbidities like diabetes mellitus, hypertension and hyperlipidemia and possible coronary artery disease. Lack of fever, which is not in our patient, and respiratory rate more than 30 per minute, which is again seen in our patient. So then the other risk factor is pathogen specific. That means all those PES and the pathogens which predispose the patient to a more severe form of community acquired pneumonia. Then the risk factors could also be because of process related. That means the patient has been treated with inadequate antibiotics, either in terms of the kind of antibiotics or the duration of antibiotics. The patient has had a delay in ICU care, or there has been a delay in initiating mechanical ventilation. So this was about assessing or making sure the patient is triaged in the right way, that the patient needs an inpatient admission in the ward or in the ICU. Now what about prognosis? How do you explain the prognosis of the patient to the relatives, or generally make a prognostic model? So for these two scoring systems there are multiple scoring systems actually, but the two which are most widely used and which are most widely validated is the pneumonia severity index, and which consists of 20 parameters which have been given different points, and according to the number of points it is classified into 5 types, and class 4 and class 5 has the highest mortality. The class 5 has a mortality of about 27%. So the other scoring system which is very easy to use is the CURB 65, which is confusion, urea, respiratory rate, blood pressure and age more than 65 years. So if the score is 0 to 1, it is a low risk pneumonia and mostly requires outpatient therapy. If the score is 2, the patient should be admitted. If the score is 3 or more, the patient stands a high risk for increased mortality and patient should be cared for in an ICU, especially if the score exceeds 3. Okay, so we talked about the chest radiograph. So what are the various patterns that you can see in a chest radiograph? The first one of our patient is a lobar pneumonia. You can see there is opacification of almost the complete lobe with some amount of air bronchograms, and the common bacteria which are associated with this kind of a picture is Streptococcus pneumoniae and Klebsiella. Then the second pattern that you see here is the bronchopneumonia, which is nodular opacities with bronchial wall thickening. So you can see these bronchial wall thickening and nodular opacities, and the common organisms responsible for this kind of picture is Haemophilus influenzae, Mycoplasma, Chlamydia and some kind of viruses. Then the third type of pattern that you can see is an interstitial pneumonia, which is typically seen like this. It's a diffuse, patchy, peribronchovascular. It seems like there is increased bronchovascular markings, which are thickened, and reticular opacities. And this is very commonly seen either in a viral pneumonia or sometimes in a mycoplasma infection, and also in pneumocystis infection, especially if the patient is immunocompromised. So the next imaging modality that one uses is, I'm sure all of you must be using. How many of you are proficient with lung ultrasound? Great, so that's very good news. So this is an excellent modality for diagnosis, especially when the patient is in unstable condition or is in the ED or in the ICU where you don't want to transport the patient for X-ray or for CT scan. So that is excellent, and it has a very high sensitivity. It is point of care and it is radiation free. So all pluses. But the only negative is that the performance is operator dependent. So you need to be adequately trained to detect a consolidation or a pneumonia or a shred sign or a pleural effusion. So ultrasound is also very good at detection of pleural effusion, a paranpneumonic effusion, which may not be evident on an X-ray, but on ultrasound you can detect even very small amounts of, even as large as 50 ml of pleural effusion can be detected on an ultrasound. So what is the role of CT scan? Do you think all patients who are admitted to the to the ICU should have a CT scan? Yes or no? How many people think yes? Okay, great. So, very well educated all of you. So, basically there is no role of CT scan, and the role of CT scan only comes in if you clinically you suspect this patient has community acquired pneumonia, but the chest X-ray is not showing anything, or the ultrasound is not showing anything. So, this could be because of many reasons like underlying structural lung disease, or the patient is very obese, you may not get a good ultrasound view, or the patient is neutropenic when they don't mount such a response to get a opacity, and sometimes very early in the disease course you may not get any finding at all. Or if the patient has an unusual chest X-ray, or there are a lot of cavities or nodules which doesn't fit into a typical community acquired pneumonia picture, or the patient has presented with an atypical, like I told you in elderly patient, there is just confusion and electrolyte abnormalities, you need to rule out any pneumonias. And if you have a possible alternative explanation, like if the patient has underlying COPD, or you are suspecting the patient has a concomitant pulmonary embolism, so you need to get a CT done, or a CT angiography done to rule that out. Okay. So what are the limitations? First, it is expensive. Second, you need to transport the patient to get the CT scan done. It is associated with a very high radiation risk exposure, and studies have shown that it does not, getting a CT scan, although it is the most sensitive modality, it does not lead to an improvement in outcome. So what are we working, why are we doing an investigation? Basically to improve outcome. So if there is not resulting in an improved outcome, what is the point, especially if it has so many limitations to it. Then lab investigations might show leukocytosis or leukopenia, thrombocytosis or thrombocytopenia, but presence of leukopenia and thrombocytopenia is associated with increased mortality, right? So there can be organ dysfunction in the form of deranged LFT or deranged renal function test, and points towards sepsis. Then procalcitonin and C-reactive protein is a good investigation to get baseline values of. It points to, even if it's not helping you decide in the therapy, at least later on for de-escalation of antibiotics, it would be a useful investigation to have. And plus obviously arterial blood gas to determine the need for oxygenation and ventilation. Coming next to the microbiological diagnosis. So respiratory sampling is a must. Okay, so all patients who are producing sputum, they should have a gram stain on sputum, and if gram stain is showing gram positive cocci in clusters, then you know for sure that's most probably streptococcus pneumonia. So you can start your treatment immediately. The cultures that need to be sent is sputum. If the patient is intubated, endotracheal aspirate, and if you are not getting a good endotracheal aspirate secretions, then probably BAL. Then nasopharyngeal swabs need to be sent for multiplex PCR, both for respiratory viruses as well as atypical bacteria. And if you are suspecting MRSA, then a nasal PCR for MRSA. And this always has to be combined with a respiratory sample PCR also, not that alone. And along with it, there are blood cultures, two sets of blood cultures to be sent. So the recommendation on this is very weak, because the blood culture in pneumonia, the yield is not very good. Okay, so only about 16% of blood cultures will show some yield. Okay, so that is why it is not really advocated, but all severely ill patients, all patients admitted in the ICU will need, according to the recommendations, 2019 recommendations, the blood cultures need to be sent. So what are the challenges in the microbiological diagnosis? The challenges could be in form of patient factors, that is the patient is unable to produce sputum, or the patient has had prior antibiotic use. So what is the, can you in any way induce the patient to produce sputum? Anyone? Correct, very good. So you can do that, but keep in mind that you should not delay the initiation of your antibiotics in the process of doing all these things. Okay, so if this is taking time, you should not wait for the antibiotic. Ideally, all the cultures should be sent before giving the first dose of antibiotic. Plus, please do not delay antibiotic therapy just because you are not able to get a sample, especially of the sputum, right? And the problem, what is the problem with the sputum culture? Do you think it's very sensitive and specific? Why? Yeah, so first it is contaminated with a lot of oral flora, and also patients do not, it's contaminated with saliva. So what is the best way to determine that a good sputum sample is that if it has more than 25 polymorphonuclear cells and less than 10 squamous epithelial cells. That means a lot of saliva from the mouth has not contaminated the sputum. So like I said, a lot of false negative and false positive results, and sometimes there can be challenges in interpreting the results of the cultures, because it's very difficult to distinguish colonization from infection. So in urinary antigen testing for pneumococcus and Legionella, the sensitivities for both these tests is same, about 75 to sensitivity, 75%, and specificity is about 95%. And the problem with Legionella urinary antigen testing is that it detects only type 1 serotype, but that is also the most commonest type of serotype, and some of the other gram-negative bacilli bacteria may generate a false positive test. And along with the urinary antigen testing, you also need to have respiratory samples for culture and PCR. So that alone is not going to suffice. So the advantage is that it's more sensitive and specific, especially in patients who are unable to expectorate, and it can give you a quick result, and it does not get affected by the antibiotic therapy. The disadvantages is that the sensitivity is less without bacteremia. You cannot do a drug sensitivity on this, and sometimes there can be a false positive result, especially if the patient has had a previous episode of pneumonia in the previous 3 months or has had a recent pneumococcal vaccine. So all of these can affect the urinary antigen testing. So the next is the multiplex molecular assays, and the most commonly now everybody is using is the BioFire, which is the pneumonia panel and the pneumonia plus panel, and it requires the lower respiratory tract specimen, and it can detect a range of bacterial and viral pathogens, and it's a useful test to perform in sick patients who are intubated on mechanical ventilation. So what are the findings that make you suggest towards the etiology being that of a viral pneumonia? So first is if you get a positive viral test, okay, influenza PCR is positive, the procalcitonin continues to remain less than 0.25 nanogram per ml. The cultures don't grow anything. There is no microbiological evidence of bacteria, and the radiographic findings are not typical of a bacterial infection. So all of these will suggest a possible viral etiology. So what about antibiotic therapy? So the recommendations say that all patients in whom you clinically suspect that these patients have a community-acquired pneumonia, they should be started on empirical antibiotics. And the standard regime in patients who do not have any other risk factors is a beta-lactam plus macrolide and or fluoroquinolone. So do you know in India, is this what we follow? What do the Indian guidelines say? Yes, Harsha? What do we say of fluoroquinolones? What are our stand on that? Yes. Yes. So we have a very high incidence of tuberculosis in our country. So this is one of the guidelines which was published in 2015. It's not a very recent guidelines, but this was put forward by the Indian Chest Society and National College of Chest Physicians of India, and they have recommended that fluoroquinolones should not be used for empirical treatment, and it should be used only if there is a contraindication to either a macrolide or a beta-lactam. For some reason you cannot use them, and even if you initiate quinolone therapy, you should first take a sample for Mycobacterium tuberculosis testing, and then only start the quinolones. Not everybody follows that, but that is what ideally should be done. Then if the patient has had any recent hospitalization or has had recent antibiotic therapy or has a high risk of MRSA, then you should add MRSA coverage in the form of either vancomycin and linezolid. So any idea which one should you would you prefer, linezolid or vancomycin? If you, how many for vancomycin? How many for linezolid? Why linezolid? Sorry? Correct. Good lung penetration. What else? Loudly. Yes, but not always an advantage. Yes, no adverse effects. And one of the serious adverse effects of vancomycin is nephrotoxicity, especially when given in combination with the beta-lactam, right? So it does not have nephrotoxicity. What is the third one? Yes? Yes, it reduces the toxin formation, which is not there in vancomycin. So, if given a choice, you should give linezolid over vancomycin. Then, along with that, you should also, before giving the MRSA coverage, you should take blood cultures and nasal PCR. So, similarly, if the patient has a high risk of Pseudomonas aeruginosa, then you can give a anti-pseudomonal beta-lactam like piperacillin tazobactam or cefepime or meropenem, and before taking, but only before giving this the antibiotic, you should take blood, sputum and ET cultures. So what is the role of biomarkers? Serum procalcitonin has been used for diagnosis, but it's not very sensitive. The sensitivity ranges from 38% to 91%. If it is less than 0.1 nanogram per ml, it points towards viral. If it is more than 0.25, it points towards bacterial. But again, like I said, there are a lot of variation. If the patient has AKI, like this patient has AKI, again there will be a rise in procal, which may not be very significant. Then empiric antibiotic therapy should be based on clinical suspicion and clinical judgment alone and not on the basis of procalcitonin. It can be used for de-escalation or discontinuation of antibiotics if the procal is less than 0.5 milligram per liter in a patient who is severely ill, or there is more than 80% decrease from baseline. So that is why you need to have a baseline value of procalcitonin. So then there is mid-regional proadenomedullin. This is another biomarker which has not been it's very difficult to do, it's very expensive, not easily available, but it has been shown to correlate well with the pneumonia severity index score, and it has been seen that it correlates well or is higher in patients with CAP who had a high mortality. So what about patients who test positive for influenza? Will you treat them? Yes, you will treat them obviously. So all patients who test positive for influenza should be given antiviral in the form of oseltamivir, and it should be given irrespective of the duration of illness. Ideally, it should be given within 48 hours of onset of symptoms. But even if the patient has come to you after that window of 48 hours, you should still initiate the antiviral treatment, and it has been seen that it reduces the risk of death, and like I said, best outcomes are within 48 hours, but nevertheless one should administer antiviral drugs. And also along with the antiviral, you should also initiate the empiric antibiotic therapy, because like I said, if you remember in the beginning I said most of these viral pneumonias also have bacterial pneumonia as well. Okay, so polymicrobial etiology is very common, or vice versa. So bacterial coverage or in the form of empiric antibiotics should be initiated. So the duration of antibiotic therapy should be between 5 to 7 days, and there has been no difference in outcomes if the antibiotic therapy was for 7 days vis-a-vis 10 days. So most people, if the patient is becoming clinically stable and is improving off inotropes, off mechanical ventilation and off fever and afebrile, then 5 to 7 days is a reasonable duration of antibiotic therapy, and procalcitonin can be used for discontinuation or de-escalation. There are certain indications for prolonged therapy of about 7 to 10 days, say in patients who have severe necrotizing pneumonia, or patients who have lung abscess, or they have a complicated pleural effusion, or along with the pneumonia have extrapulmonary infections. So there a prolonged therapy of 10 to 12 days is indicated. So risk factors for drug-resistant pathogens, like I've been mentioning in the previous slides, is prior colonization with the PAS pathogens, contact with the healthcare environment in the past 90 days, which could be a prior hospitalization or recent ICU admission, hemodialysis patients, very prone to drug-resistant pathogens, nursing home residences, patients who have chronic home wound care, patients who have chronic home intravenous antibiotic therapy. All of these have an increased chances of developing drug-resistant pathogens. Then coming to the specific host disease risk factors in the form of immunosuppression, bronchiectasis, diabetes, heart disease, or respiratory disease, or even cerebrovascular diseases. Then specific therapies in the form of patients who are on tube feeding. These patients are more prone to aspiration. Patients who are on gastric acid suppression therapies, again because of aspiration, and corticosteroids and other immunosuppressive therapies. These are some of the new antimicrobial agents because seeing the rise of the multi-drug resistant pathogens, some of the newer antibiotics have been kind of introduced, which have been FDA approved now, not presently available in India. I haven't used any of these, and they're not being widely used, again for the same reason, for the fear of developing resistance. Okay, so when do you use NIV and HFNC? This indication remains the same for any critically ill patient, but if you need to reduce the work of breathing or improve oxygenation or avoid intubation, both NIV and HFNC can be used safely. And HFNC, as you all know, is so much more better tolerated than NIV, but the indications for the two are very different. There are no studies comparing these two modalities in patients with severe CAP. So then role of adjunctive corticosteroids. So according to the 2019 guidelines, there is no role of adjunctive corticosteroids because there is a lot of conflicting evidence. Some studies says that it improves mortality, some studies says there is no effect on 28-day mortality. It is recommended only in patients with refractory septic shock as part of the surviving sepsis guidelines, okay, according to the 2019 guidelines. It is definitely not recommended in non-severe community acquired pneumonia. Patients who are not in the ICU should not be administered steroid at all, and in influenza pneumonia. Patients who have pneumonia because of influenza virus should not be administered corticosteroids, and there is a lot of evidence to say that it increases mortality. So now this is in recent I think this month NEJM, we have a very large trial, a randomized controlled trial of hydrocortisone in severe community acquired pneumonia, where they looked at around 800 patients, and the primary outcome was 28-day mortality, and they found that the 28-day mortality was significantly less in patients who were administered hydrocortisone 200 milligram per day. So this could be a game-changing because this was a very nicely done randomized controlled trial. So maybe in the next revision of the guidelines, this might come in. So the complications are pleural effusion, multilobar involvement, empyema, and in more than one complication can be seen in about 20% of the patients. These patients can also have cardiovascular complications in the form of myocardial infarction, arrhythmias, and congestive heart failure. So to summarize, community-acquired pneumonia is the leading cause of morbidity and mortality worldwide. So clinical assessment and lab evaluation is the key to diagnosis and treatment. Empirical antibiotic therapy should be started based on severity of illness, site of care, and most likely pathogens. And the microbiological diagnosis should be done it's very important to target the antibiotic therapy, and prompt de-escalation should be achieved after 5 to 7 days. So I was asked to prepare these MCQs. I think the answers to most of this I have already told you in my presentation, but just for the sake of completion, which of the following imaging modalities is most sensitive for detection of pneumonia? So just raise hands, I'll ask you. Yes, very good. So CT scan is the most sensitive, followed by this, and this is obviously not used. Very good. So the antibiotic of choice for treating a patient with CAP who has multiple pustules on the skin is vancomycin, linezolid, teicoplanin, and daptomycin. Somebody else? Yes, Divya. Very good. So the answer to this MCQs also I already told you. So that means all of you are listening. Then the third MCQ, which of the following statements regarding urinary antigen testing is not true? Yes? Yeah? Yes? No one? Yeah. Affected by antibiotic therapy. Very good. So it is not affected by antibiotic therapy. Great. Thank you so much. Not really where it is indicated. It should not be reserved for it.